Simon Scarf from the Desmond Tutu TB Center, and next to me is Khurshid Talukdar from Bangladesh, who's my co-chair. This session is an oral abstract presentation, and it's a quick session of 10 minutes talks, and people have to stick to their time, please. Very important, because at least 2 of the speakers have to catch a train at 3:45. So if we don't stick to our time, they're going to miss their planes. So I'll be waving the time sheets as we go along. So let's start. Our first talk is by Jeffrey Hafkin from Otsuka, who's going to speak on delaminate in the age group 7 to 11 years.
Hello, everyone, and thank you so much for inviting us to speak. I'm going to speak briefly about some of the latest results from our first 2 groups of patients who have received long-term treatment with delaminate. And actually, it was a surprise to me. I didn't realize that the WHO was going to release a guidance statement on the use of delaminate this week. A lot of the data I'm presenting is actually embedded in that report, so I highly recommend those who are really interested in the PK and safety results to take a look. And again, this is data on patients who are above the age of 6, but it does include long-term data, and this is using the solid adult formulation. So, as I think I've mentioned in prior talks at this meeting, we've been working on a standard traditional age de-escalation clinical trial of delaminate in children added on to an optimized background regimen. There's 2 parts to this trial. There's an 18-day PK study followed by 6 months of delaminate exposure added on to standard WHO MDR-TB treatment. And currently, we've completed enrollment and basically completed the long-term follow-up for groups 1 and 2. We are almost finished studying the pediatric formulation in children ages 3 to 5 years old, and was just talking with Tony, one of our PIs, that hopefully we'll get our amendment filed soon to begin enrolling newborns up to 2 years old. And these are pictures. I don't know if there's a pointer here, but this is how the dispersible tablet will be administered, either using a cup or a syringe. And just to let you know, we have completed 7 patients in group 1, 6 patients in group 2, and the age ranges are 13 to 17 in the first group, 7 to 11. We have more males than females in the first group, more females than males in the second group, and you can see the weight and BMI ranges that were exposed to delaminate. Another point, we are recruiting patients in both South Africa, Brooklyn Chest Hospital, and Philippines in the greater Manila area. And just to note, the first group had only patients from the Philippines because it started enrolling prior to South Africa, but now we're aiming for parity in all of our age groups. One thing that's not surprising, as we move to younger age groups, we have more presumptive and less confirmed MDR-TB, and when we are able to present the younger groups, the next younger group, you'll see that that is the same. And the same with extrapulmonary diseases, not surprisingly, increases in the younger age groups. Just to show you some the safety data from 232. For those of you who know a bit about the pharmacology of delaminate, there is the primary metabolite, DM6705, is what we think is most likely to be associated with QT prolongation or key safety signal. And that doesn't reach steady state till after at least, it needs almost a month or more. So it's not surprising there's very little change or categorical change in QTcF over the course of the PK study. And I think the safety information is more useful to look at the longer term exposure to delaminid. And as you can see, all 7 patients in the first group have completed their end of MDR treatment, and we're actually almost, this should be updated. I think we only have 2 patients left who are still waiting for their final treatment outcome. And then, so I think it's more important to look at QT data in the longer term exposed groups. And basically, we're seeing roughly lower QT levels than in adults and children. And I think there could be a trend in the younger aged patients compared to the older age patients. But I think this will need to be borne out in larger trials. And for those of you who aren't aware, we're collaborating with the Impact Network for a subsequent trial of delaminid for patients who have HIV and MDR-TB. And hopefully that will include an injectable-free regimen. So we'll get more data on QT and safety. But here's the actual raw data looking at mean QT, and in terms of actual categorical cutoffs, only 1 patient had to change baseline to follow-up of greater than 60, none greater than 500. And just to mention that 1 patient that was greater than 60 actually had Wolff-Parkinson-White syndrome at baseline, unbeknownst to us. And from everything I've discussed with cardiologists, it is not useful to look at the QT interval. All bets are off in the setting of Wolff-Parkinson-White. So in terms of most frequent side effects, adverse events, these are the most frequent, and a lot of these were most commonly attributed to the optimized background regimen. Thus far, no patient has had to stop delaminid permanently because of any adverse event. And just to show you, in terms of long-term PK data, we're seeing exposures in the first and second groups that are well above the standard acceptable PK exposure that we saw in our adult phase 2b clinical trials. So we're fairly confident that in terms of getting the right delaminid exposure, we've been able to do that with this study. And one of the other interesting findings is actually over the long term, we're seeing less accumulation of the metabolite DM6705, at least a trend of lower accumulation of the metabolite in children than we are seeing in adults. And I think that's also being borne out with what we're seeing clinically. So, I'm hoping with larger studies, more exposure, use of delaminid, either through the compassionate use program, some of the expanded access program. I think MSF and Partners in Health are using delaminid in children. We'll get a better sense for the overall safety profile. But thus far, what I can say is all patients are alive, and with the exception of one of our adolescents who, after completing delaminid and midway through finishing her OBR, said she had had enough. She became pregnant, still alive, doing well, baby's doing well, We're still following her, but would not take any more MDR therapy. But everyone, all the patients are alive and doing well thus far, and we're pleased that this could inform the WHO guidelines, and hopefully in the future, more data will be made available. So thank you very much.
We'll allow for one question. Yeah, James?
You've chosen to go for these age bands, which have quite a wide range of weights in them. I think why did you choose to go that approach rather than trying to determine what the milligram per kilogram dosages for an individual and then calculating the most appropriate weight bands or age bands to deliver those?
Yeah.
Why did you go that way?
So it's an excellent question, and I think our pharmacologist's ultimate goal is to take the data that's been generated from these studies plus the impact study, and using PK/PD modeling, derive what would be the most appropriate weight-based dosing. So what I can say already, when we provide Dilaminid for compassionate use, we actually do use weight cutoffs. So for the adolescents, we recommend the 100 milligram BID dose for those over 35 kgs. Those under 35 kgs, we're recommending 50 milligrams BID. And this is based on the updated modeling, and my understanding is this is what's going to inform the dosing for the impact study.
But you're not recommending they have 50 milligrams per kilogram or something like that?
Right now we're using weight bands, but certainly, and you know, Tony, I don't know if you have thoughts. I mean, we're open to suggestions, and what we'd like to do is use what is most scientifically valid and what is most applicable to the community.
Okay. Yeah, we actually have to move on, but people have to catch trains, but at the end we'll have some more questions. Right?
So our second speaker is Tony Garcia-Prats from the Desmond Tutu TB Center, speaking on the effect of co-administration of lignocaine on pain and pharmacokinetics of intramuscular amikacin in children with multi-drug resistant TB.
Yeah, thanks and good afternoon, and thanks for everyone for sticking around to the end of the conference. I think most of us are aware that current guidelines recommend 4 to 6 months of a second-line injectable TB medication be used in the treatment of MDR for both adults and children. This requires administration of usually daily intramuscular injections, at best thrice weekly intramuscular injections. These are painful, they're very poorly tolerated. It causes a lot of distress, obviously, for patients, both adults and children, particularly for children, their caregivers and parents as well, and healthcare workers who actually have to administer these injections. So strategies are urgently needed to improve their tolerability. One such strategy that's been employed with other antibiotics is to add lignocaine to the intramuscular injections. There's multiple publications with ceftriaxone and penicillin, including in some cohorts with adolescents. And these 3 publications at least have shown that this approach was safe, it reduced pain, and it didn't alter the pharmacokinetics of ceftriaxone or penicillin. Amikacin, just as a quick reminder, is rapidly absorbed after IM injection. It's renally eliminated, unchanged, and the PK parameter that's most closely associated with efficacy is the Cmax. So the objective of this study was to compare the pain and PK of intramuscular amikacin when given with and without additional lignocaine among children routinely treated for MDR-TB. So this study was a randomized, blinded, 2-period crossover study. It was implemented in Cape Town, South Africa. Children were included if they were 8 to 18 years of age and routinely treated with amikacin for MDR-TB. They were randomized to one of 2 sequences. The first sequence was an amikacin injection with lignocaine, and then subsequently one without. And then in sequence 2, an amikacin injection without lignocaine, then subsequently with. We used block randomization, and the sequence generation was via computerized random number generator. We used sealed opaque envelopes for allocation concealment. That both the patient, family, and the study team, other than the personnel who were drawing up the injection and our statistician who generated the randomization, were all blinded to the allocation. A standard lignocaine dose was used, and that table on the bottom right shows our approach. We kind of used weight bands to sort of minimize the volume of lignocaine and sort of keep it within the acceptable range of doses. We used a standard amikacin 15 mg per kg exact dose on the day of PK sampling, and then we had samples pre-dose and then at 1, 2, 4, 6, and 8 hours post-dose. For the pain assessments, we used the Wong-Baker FACES pain scale, which you can see on the bottom left of the slide. This is a validated pain scale for children. And we did assessments pre-injection and then immediately 30 and 60 minutes after injection. Our PK endpoints were Cmax and AUC 0 to 8, and our endpoints for pain were the adjusted pain scores. And by adjusted, I mean that we actually took the post-injection pain scores, subtracted the pre-injection pain score, because these children are having daily injections. They had a lot of pre-existing pain from their injection in that butt 2 days ago. For statistical analysis, we used the Wilcoxon signed rank test for paired data. Oh, and sorry, it's important actually to mention this study was ethically approved by the Stellenbosch University Ethics Committee, and patients and participants, the adolescents and older children, did provide assent. So 12 children were included, a median age of 11 and a half. 8 were male, 3 were HIV infected, and 4 had a low weight for HC score. So getting to the pain scores, in the first column are the pain scores on the occasion without lignocaine, the second column with lignocaine. So the median adjusted pain score immediately after the injection was 2.5 on the occasion without lignocaine and 1 on the occasion with lignocaine, and this was a statistically significant difference. The median pain score 30 minutes after the injection was 1 in the without lignocaine occasion and 0 in the with lignocaine occasion, and the same 60 minutes post-injection. Those weren't statistically significant differences, but I think it is worth noting that the pain score in the with lignocaine occasion was 0, which indicates no pain. And if you look at the IQR, you see that the lower end is a negative pain score. So actually, these children had lower pain post-injection than they did pre-injection. So I think all of this supports that the lignocaine was significantly reducing the pain. Taking a look at the PK, this is just a graphical representation. The blue crosses represent the individual concentrations on the without lignocaine occasion, and the blue bar, the median values, and then the red circles, the individual concentrations on the with lignocaine occasion, with the solid red bar being the median. And you can see, with the exception of a few outliers, these clearly overlap substantially. And looking at this quantitatively, the median AUC 0 to 8 on the without lignocaine occasion was 103.3 and 109 on the with lignocaine occasion, and there was no statistical difference here. And same with the median Cmax was 34.1 in the without lignocaine occasion and 36.7 on the with lignocaine occasion. Again, no difference. There were no adverse events related to the lignocaine injections during the study. So to summarize the findings, the addition of lignocaine to IM injections of amikacin reduced injection pain significantly. It was safe in this small cohort, and there was no significant effect on amikacin PK. So there are some limitations to this study. This was obviously a very small study, so we may have been underpowered to detect differences in pain in the 30 and 60-minute time points. We weren't powered to demonstrate bioequivalence, which may have been a more rigorous assessment from a PK perspective. But we still feel quite reassured by these results. And we feel that second-line injectables, when required to be given, really should be given or co-administered with lignocaine. And ultimately, the goal still needs to be to limit or eliminate the need for the injectables. I'd like to acknowledge the funders and collaborators, and particularly the patients and parents.
Thank you, Tony, and also for sticking to time. Any questions? Yes, Anna.
Yeah, I mean, it's not impossible. I think at a programmatic level, it's just not feasible to do that for every child with MDR-TB. I mean, there's issues with just getting the lines placed. And I think, there is the surgical capacity that you could probably do that. I don't know about for the volume of children. Oh, you mean peripheral lines? Peripheral lines. Yeah, so, a PIC. So yeah, I mean, you could do that. I think there might be capacity. You might have a better idea of whether there would be capacity to do that. But I think the main issue would just be maintaining those lines, and the risk of infections in this context, I'd be quite concerned about that. The risk of infection in many settings is not low. In our setting, I think it might be quite high. I'd be concerned about that, and for children to be able to access care quickly if they did have a line infection. So that would be my concern about doing that. I think there'd be circumstances where it might make sense.
Yeah, actually, at the hospital where we treat most of our children with amikacin, they do not manage any lines. So any child that needs a line goes back to the original hospital. So we don't do any IV lines at Brooklyn, for instance. And the same goes for the other TB hospitals.
I can see how that would be an attractive option in many settings.
Tony, you have another talk, so I think you should continue.
Okay, good. Did I buy myself a few extra minutes for this talk? No? Okay, so I'm going to present some of our data on the PK of levofloxacin in kids with MDR-TB. Levo has a critical role in current MDR-TB treatment regimens. This is particularly true for children. Moxie is only available as a 400 milligram unscored tablet. It's difficult to split and appropriately dose. When crushed, it's very poorly palatable, so Levo has been really the quinolone of choice for children globally. It's a component of multiple novel regimens under evaluation, and one reason it's particularly attractive is that it has a lower propensity to prolong the QT intervals, so potentially could be used at a higher dose, or higher doses are being explored, and could be combined more safely with novel TB medications which cause QT prolongation. For children, it's particularly important because of preventive therapy, so there's 2 clinical trials that are starting or ongoing looking at levofloxacin as monotherapy for MDR preventive therapy. So despite its critical role currently and in future, the optimal dose for MDR-TB in children is not known. The approach to pediatric dose selection traditionally has been to identify doses in children across weights and ages that result in exposures that approximate those in adults who are receiving the recommended efficacious doses. So we need to understand the PK of the medication in children with TB. So Levo is a fluoroquinolone. It has good oral bioavailability. It's eliminated unchanged in the urine. The target is the AUC in adults with whatever dose it is that you're targeting. And the most frequently used dose, at least currently for Levo in adults, is 750 milligrams once daily. The currently recommended pediatric dose is 7.5 to 10 milligrams per kg, given twice daily in younger children, once daily in older children. And there is some existing pediatric PK data. We published a small cohort of 23 children receiving a 15 milligram per kg dose, and we showed that it results in low exposures. And there have been some other cohorts, a nice study from Micronesia, which reported similar findings. So this data is from the MDR-PK1 study. It's an NIH-NICHD R1 funded study being implemented in Cape Town. Children were included if they're HIV infected or uninfected, less than 14 years of age, and routinely receiving levofloxacin either for treatment of MDR or as preventive therapy. Children received doses either of 10 to 15 milligrams per kg or 15 to 20 milligrams per kg, and after we did some interim analysis and showed low exposures with 15, and sort of midway through the study, we increased the dosing that we were providing to children. They received the Levo orally or via an NG tube as a whole tablet or a crush, just kind of depending on what they could tolerate. You can see the sampling schema there, and the assays were performed at University of Cape Town. Paolo Dente, also at UCT, performed this analysis that I'm presenting today using nonlinear mixed effects modeling and simulations. So 109 children were included. The median age was 2.1 years. You can see the range, 0.3 up to 8.7. This is a large proportion of these children are young, which is important because that's where we see the most PK variability and also where there's the most gaps in the current literature. The fact that there were no older children is really just an artifact of the recommendations in South Africa to use Moxie in older children and Levo in younger children. An even gender distribution, 14.7% of the cohort was HIV infected, and roughly half of the patients in each dosing strategy. You can see few children were actually able to swallow the whole tablets, which is also informative in itself. The majority had crush tablets, and the vast majority received on the PK sampling day, Levo via NG tube. This is not what was done in routine care. This was just to ensure that the full dose was received so we could interpret PK, but NG tubes aren't used routinely on a day-to-day basis in routine practice. So a little about the model results. This was a 2-compartment structural model that was used. Allometric scaling on clearance and volume improved the model fit, so it was included in the final model, and this is just a way to account for the effective weight on these parameters. There was a maturation effect on clearance that was identified, and this isn't surprising. So this is a renally eliminated medication. Renal function develops over time from birth. That has important effects on the exposure. So we were able to characterize that and quantify it well since we had a large population of young children. Interestingly, HIV resulted in a 16% slower clearance, so we're not entirely sure why that is or whether it's really clinically significant. We don't think so. An administration method affected the speed of absorption, which isn't really surprising either, but it did not affect the overall bioavailability, so crushing did not reduce total bioavailability. So using the model, Paolo simulated the AUCs that we would see, assuming an exact 20 milligram per kg dose, and this is not to suggest this is a feasible or practical strategy to deliver an exact dose to children, but just to see what exposures would look like. And so on this figure, on the x-axis is weight, on the y-axis is Levo AUC. And you can see in the green hashed line is the median AUC in adults after a 500 milligram Levo dose. And the exposures across weights reasonably approximate those adult exposures. You can see the younger, some of the smaller children are a bit underexposed, but not too badly. But you can also see those exposures are well below what would be seen after a 750 milligram dose across all weights, and even further below, obviously, after a 1,000 milligram dose. So what doses would be required to provide exposures across weights that would approximate a 750 milligram adult target, which is what's being used in adults? That's the figure on the left. So Paolo did these simulations after generating weight bands, weight-banded dosing of Levo, and so those AUCs on the left figure are around, the hashed red line is the 750 milligram AUC adult target. You can see these are the weight bands he settled on that fit well, and if you look at the bottom row, these are the milligram per kg doses that were required to achieve those exposures, which are clearly much higher than we're dosing now. Really, across weight bands, except for maybe the oldest, are really looking at 30 to 40 milligrams per kg. But this obviously has important implications, and we were curious about what Cmaxes we would see using this weight-banded approach, and that's the figure on the right part of the slide. On the x-axis in that figure are weights, and on the y-axis, the Levo Cmax. The red hash line is the median Cmax in adults after a 750 milligram dose, and the green hash line after a 1,000 milligram dose. So you can see using this weight-banded approach, if it's given in a once-daily fashion, the Cmaxes are quite high. They even exceed what's seen in adults after a 1,000 milligram dose, particularly at the younger ages. So this has important implications potentially for safety and tolerability, and I think a lot of thought needs to be taken about how we want to take Levo dosing forward. So some summary points and way forward. Levo at 15 to 20 milligrams per kg still resulted in lower AUCs relative to a 750 milligram dose in adults. I haven't presented it here. We presented earlier in the year in some different forums, some safety data from this cohort. And what we saw is that children receiving 15 to 20 milligram doses, it was safe and well tolerated. So one of the take-home points is that really we think clinicians in the field should be using at a minimum 15 to 20 milligram per kg once daily, probably dosing in the high end of that range, feeling confident that children, at least from our data, will tolerate that well and that it's safe, and even at that dose, exposures are going to be low. But I think the question remains, do we want to take Levo doses higher for MDR-TB treatment? And actually, I should take a step back. The 15 to 20 milligram per kg dose is what we will be using and rolling into the TB CHAMP study, which is the MDR preventive therapy study. But for MDR-TB treatment, should we be considering higher Levo doses? I think there's a case to be made for that. This might potentially improve outcomes further, and certainly outcomes are better in children than in adults, but there's still scope to potentially improve them. Importantly, it may facilitate us giving shorter or injectable sparing regimens. We want to remove the injectable, and I think we'd all be more confident doing that if we know that we could have good exposures of our quinolone, which is a key component of current treatment regimens. This also may be important for bridging to novel regimens that are being studied in adults. Any decision about increasing Levo beyond the ranges that we've currently been doing needs to carefully consider the impact on safety. So thanks again to the funders and collaborators and patients and their parents.
We have time for one question. Yes, Andrew.
Andrew, thanks very much. As clinicians, should we be thinking anything differently if we have a child who we think might have a dysbiosis in their bowel from a microbiome standpoint, or a child who's got bowel inflammation for any reason? Does that impact on any of this, or do we still not know?
Like from an absorb, maybe they won't absorb as well. You know, I'd be guessing, I mean, we don't really, we weren't able to look at that in our study, and actually most of the children in our study had been on treatment for at least 2 weeks, so many of them weren't really acutely ill, so we can't really say very much about that kind of effect. Levo has good bioavailability, it's rapidly absorbed, nearly 100%, so I would suspect that that effect might be relatively minimal, but I couldn't say for sure. I probably wouldn't alter dosing.
Okay,
Thanks.
Thank you very much, Nadine. So our next speaker is Dr. Sylvia Chiang from Brown's University in the US, who also works in Peru, and she's going to present on baseline predictors of multi-drug resistant tuberculosis treatment outcomes in children, a retrospective cohort study.
Hi, good afternoon, and I apologize for anybody who was at the MDR symposium yesterday because I'm presenting the same data, so please feel free to tune out. Okay, I have no conflicts of interest to declare. And what I'm presenting today is the results of a retrospective cohort study conducted by me and a group of co-investigators from both the US and Peru. We conducted this cohort study in Lima, Peru, and we had a number of research questions for this study, but what I'm presenting today are the results of the first analysis, and the goal of this first analysis was to identify baseline predictors of treatment outcome in children and adolescents with MDR, specifically looking to see if we can identify modifiable risk factors that would help us identify targets for improving treatment outcomes. So the setting, for those of you who are not familiar with Peru, Lima is the capital, and the total TB incidence in the Lima area is about 200 per 100,000 per year. The HIV burden in Lima is low. So among adults, it's 0.3% incidence, and among TB patients, about 6% prevalence of co-infection across all ages. In Peru, we have about 5% of new cases are MDR and 25% of retreatment cases are MDR. And across all ages, the treatment success rate for MDR is 55%, which is about the same as the global treatment success rate for MDR. And in Peru, MDR treatment is individualized to the patient's DST result. In the case of children, that is going to be most likely individualized to an identified source case's DST result. And treatment is, for the most part, ambulatory unless there's a clear indication for hospitalization. So all patients with an indication for a second-line drug, all patients with TB are reported to the NTP, but specifically patients who get a second-line drug have more detailed medical information stored at the NTP headquarters in Lima. And so we had access to this repository of clinical data, and we selected out the children who were between the ages of 0 and 15 at the start of their MDR treatment between 2005 and 2009 in metropolitan Lima. And the reason that we excluded children from the rest of the country is because there were so many gaps in the clinical data for those children. So we included children with either confirmed or probable MDR based on the Sentinel Project consensus research definitions. For those of you who are not familiar, the confirmed MDR being a patient who has MTB isolated in a sample with genotypic or phenotypic MDR, and probable MDR being that the child had clinically diagnosed TB disease and an identified source case with confirmed MDR. So we abstracted data from these clinical charts over 200, 300 data points per patient. And because we had so many data points, we implemented a number of quality control measures, including duplicate chart abstraction. So what we wanted to do was identify any variables that were associated with treatment outcomes, and we looked at patient-related variables and regimen-related variables. So in this particular analysis, we looked at baseline variables. For patient-related variables, we identified baseline as measured prior to or within the first 7 days of treatment initiation, and we looked at a number of different factors that either had previously identified associations in adults and other childhood cohorts, or that we thought may have reasonable associations with treatment outcome. So we looked at demographics, we looked at anthropometrics, we looked at anemia, whether or not the child had an identified MDR source case, results of routine laboratory microbiological studies, and whether or not the child had confirmed versus probable MDR, and the disease severity as defined by the Wiseman criteria, which was also another consensus definition paper. And the Wiseman criteria were incorporated into the Sentinel project definitions. So we looked at regimen-related characteristics, and we, in this case, defined baseline as the group of drugs received during the first month of therapy, and we excluded drugs that were only received for a few days. So any drugs received for less than that month, we excluded. And what we looked at was the number of likely effective drugs based on the DST result, and also whether the use of a likely effective pyrazidamide injectable agent, moxi, or ethionamide was associated with treatment outcomes. We chose those characteristics because in adult studies, they had been associated with treatment outcomes. So to perform our analysis, we used regression, and we looked at these independent variables with 2 treatment outcomes, the first being a combination of death and treatment failure. We compared those kids with death or treatment failure with kids who were cured or probably cured. Probably cured is the same as treatment completed. And we looked at the association between the independent variables and loss to follow-up. So we compared children who were lost to follow-up with those with any known outcome. And we took the variables with significance at or below 0.1 in the univariable analysis and put those in a multivariable model with the help of stepwise regression because we actually didn't have that many poor outcomes. We included age in all the final models because of its known association with treatment outcomes. And because we excluded children with unknown outcomes, we used Fisher's exact test to compare those with known versus unknown outcomes to look for bias, and we didn't find any differences across the characteristics we looked at. So we reviewed a total of 372 charts, and just to get to the point, we excluded duplicate patients, those who didn't start treatment, those who didn't meet criteria for confirmed or probable, and our final sample size had 232 patients, about half and half confirmed and probable MDR. And baseline patient characteristics, about half and half male and female. I'd like to point out that most of our patients were actually 10 to 15 years old. We had a surprisingly low number between 0 and 4 years of age. We had 28% with a weight for age Z-score less than or equal to -1, 7% with previous TB episode, which is not surprising since this is a childhood cohort, 89% with identified MDR source case, 34% with severe TB disease, and for those of you who are not familiar with the Wiseman criteria, in general, that is based on chest x-ray findings, so bilateral disease or cavitary disease would be severe, and extrapulmonary disease, so for example, CNS disease would be considered severe. 50% were AFB smear positive, but 10% had no results. 55% were culture positive, but 22% had no results. And we had very few HIV-infected children, only 2 in our whole cohort, and few children with either confirmed or probable XDR 8. So in terms of the regimens, about 66% received at least 5 likely effective drugs in the first month, 88% an injectable agent, 47% pyrazidamide, 43% ethionamide, and 22% moxifloxacin, with the rest receiving Cipro. So overall, our children did quite well, 70% treatment success. We did have 13% loss to follow-up, 8% death or treatment failure, and 9% we didn't know what happened to them. So when we looked at our, a couple of things here, This is the chart for multivariable analysis results. You may be asking why we looked at 0 to 9 versus 10 to 15. So when we did our univariable analysis, we actually broke it up into 3 age groups, 0 to 4, 5 to 9, and then 10 to 15. But we didn't find any differences between the 2 youngest age groups, so we grouped them together for the multivariable analysis. And then similarly, you may be asking why we chose these weight for age Z-score classifications, greater than -1 and less than or equal to -1. And again, for our univariable, we actually broke it up further into greater than -1, between -1 and -2, and less than -2. And because we didn't find differences between the bottom 2, again, we grouped them together. So in our multivariable analysis, what we found is that if you have a weight for age Z-score less than or equal to -1, you have a 3.4-fold increased risk of death or treatment failure. And then if you have severe disease, you have a 5-fold increased risk of death or treatment failure. Unfortunately, we did not identify any variables associated with loss to follow-up. So what does this all mean? Why is this study worth even talking about? I think that one thing that is important is that it is a large cohort of MDR, children and adolescents with MDR-TB outside of South Africa in a low HIV burden setting, and with fully ambulatory treatment. And it shows that these kids actually had a pretty good treatment outcome overall. And what's interesting is actually something that Tony pointed out when we were just chatting yesterday, is that these children had a pretty good treatment outcome, despite the fact that we were using, this is an old cohort, and we're using actually fairly old drugs, had a lot of PAS, and most of the kids received Cipro instead of Levo. They still had pretty good treatment outcomes. So it may seem obvious that kids with severe disease did worse. I think I should hurry up. I'll just mention that one thing that might be useful from this study is that the Wiseman criteria may be useful for deciding which children may be treated more or less aggressively in prospective studies. Low weight for age was associated with poor outcomes, and we don't really know why, because we can't tease out whether it's chronic malnutrition, acute malnutrition, whether it has to do with micronutrient deficiencies. But some further investigation with this area may be helpful to try to point to nutritional factors that could be modified to improve treatment outcomes for kids. We didn't find any associations with regimens, but we couldn't examine injectables because we didn't have enough patients who didn't get them. And it's plausible that when we look at our regimens in full detail for the full course of the disease, we may find something. We couldn't find any associations with loss of follow-up, but our data source really didn't have very detailed social demographic variables. So as with any retrospective study, we had a number of limitations, including missing data for both the outcome and the independent variables. And for our regimen analysis, we had a number of limitations because we looked at just the first month in this particular analysis, and we assumed the same drug susceptibility pattern for the patient as for the source case, and there are the inherent limitations of resistance testing. So in the future, what we'd like to do now, what we're planning to do right now, is to conduct a more detailed analysis of the entire treatment regimen. We'd like to identify early surrogates of final treatment outcome, like the culture conversion for adults. We may combine our adolescent data with earlier cohorts to examine adolescent MDR-TB in more detail. And it would be, what we would like to plan is a prospective study to clarify predictors of loss to follow-up and different aspects of poor nutrition, and potentially even modifiable causes of disease severity, such as delay to treatment initiation. Thank you.
I think we'll have to leave the questions for later.
Okay.
So
next speaker is Karen Dupreez from Cape Town, is it? Yeah, and the impact of household environmental tobacco smoke exposure on risk of TB infection in children with household TB exposure.
I'm just waiting for my slides quickly, please. Well, hi everybody, and thank you very much for the opportunity to present some more data from South Africa with you today. Thank you very much. So there's really a large body of evidence that shows that tobacco smoking, as well as passive smoking, increases the risk of both TB infection as well as TB disease in adults. However, very few studies included data on children or specifically focused on children. And 2 systematic reviews that were published last year really highlighted the need for good quality data on children and really asked that there's a more high quality research to look at this area. So we set out to investigate the association between household environmental tobacco smoke, or ETS, exposure and prevalent Mycobacterium tuberculosis infection in children with household TB exposure. And our primary aim was to really assess the strength of the association between the exposure and the outcome, but also to see if we could maybe find a dose response, which would obviously provide more evidence of a causal nature of the relationship. So this was a secondary data analysis of a large prospective community-based household contact tracing study, and TB index cases were recruited from 3 community TB clinics in Cape Town, South Africa, within 3 months of starting TB treatment. And index cases were enrolled through 2008 up to mid-2012. After enrolling the adult TB index case, household visits were conducted, and all the child contacts that lived on the same plot as the index case were eligible for enrollment into the household contact tracing study, given the age of 3 months to 15 years. Sorry, I didn't mention that. So data were collected on demographic, clinical, and household variables through structured interviews with the parents or caregivers. And we also collected detailed information on smoking exposure during these interviews. All children were screened for HIV and also for TB at baseline. They all received chest radiographs, and they also had 2 specimens sent for bacteriology, respiratory specimens. And then they were referred for TB treatment or for IPT if, as necessary, or if they were eligible. And they received that within the routine TB program. Then to measure TB infection, they all received MANTUs or TSTs, as well as IGRAS, and we used the quantiferon gold in tube as well as T-spot TB testing, and they received this at baseline at month 3. So TB infection was obviously the main outcome, and this was defined as a positive tuberculin skin test, more equal to 10 millimeters in HIV-uninfected children, and more equal than 5 millimeters in the HIV-infected children. And this is the sort of standardly accepted guidelines in our setting where the majority of children is BCG or are BCG vaccinated. And then for this analysis, we pulled the IGRA results. So if you had either a T-spot TB or a quantiferon golden tube that were positive, you were classified as being positive via IGRA. So we performed multivariate analysis using a random effects logistic regression model to adjust for the household clustering effect. And we decided to include age, previous TB treatment, as well as TB exposure as a priori variables. And obviously, TB exposure would be a major confounder in this study. So we used a contact score that has been well validated in our setting. And it's a 10-point scale, which takes into account the proximity of the child to the index case, the infectiousness, and the duration of exposure. And we added that as a continuous variable into the model. And then we used a causal modeling approach because we were really interested to find the least confounded effect estimate of smoking on TB infection. So in total, we had a cohort of 671 children, of which just more than 50% were younger than 5 years of age. Gender were equally distributed. The majority were of mixed race ethnicity. And then I think what was really striking was that 3/4 of these children were already exposed to smoking in the households. So very high prevalence of smoking exposure in the TB households. And 51%, so 342 out of 665 that had a TST result were TST positive, and 378 out of 663 who had a IGRA result, so 57% were IGRA positive. And I think this is also remarkable because it's very high rates of infection, especially given the fact that the code, 50% of the code were less than 5 years of age. So in the final model, we ended up including age, TB exposure, previous TB type of house, structure of the house, and having a cellular telephone. And after adjusting for all these confounding variables, the odds of TB infection were 3 times more likely in children exposed to environmental tobacco smoking in their households. And this was consistent between the outcomes of TST or IGRA, so irrespective of what we used. And then we also did manage to observe a dose response. So the odds of TB infection increased with 1.6 times for every 2 additional smokers that were reported in the household. Then we went on and we calculated a population attributable fraction using the more conservative IGRA-based estimates. And I think what we just do need to remember is that when you look at a PAF, you always need to also take into account the prevalence of the exposure. So in this setting, with such a high prevalence of household smoking exposure, 56% of our TB infections in children following household TB exposure could have been prevented if there were nobody in the household that smoked. So what we've shown is that there's a very high burden of smoking exposure in TB households in our community. And the strength of the association that we found, as well as the dose response, I think really supports that there's a strong and consistent evidence that smoking exposure increases the risk of TB infection in child TB contacts. And given this high population attributable fraction, I think it really highlights that smoking cessation programs could have a considerable impact on TB control, as well as prevention of TB transmission in settings where both TB and tobacco usage is highly prevalent. One of the limitations, to maybe just note there, is that we weren't able to measure objectively the level of ETS exposure in the child. That was beyond the scope of the study. But usually people would underreport, so we don't think that this would have been a major factor in this analysis. And then I just want to acknowledge, obviously, the parents and their families, the whole team of people conducting these large study, and collaborators and the funders. Thank you.
So because you were within your 10 minutes, we have time for questions. If there's no question, I'm going to ask one. So what would you think is the reason why children in households where they're smoking had more infection? Because I would think maybe more disease, but why more infection?
Well, I mean, the disease is obviously the next step. And the thing is that the next analysis that we're planning is to look at disease, and that infection is sort of just the proxy. So if there's more infection, we assume that there would be more disease in those households. But I think if one just think about the fact that there were more infections, there's 2 hypotheses. So either in the individual, as we know, smoking can cause maybe increased susceptibility of the pathogen to be, so the patient's more likely to become infected. But I also think that there's a lot of health systems. This highlights a lot of health systems around households with tobacco. And if there's prolonged infectiousness potentially of source cases who have TB and is smoking, the exposure to the child may be more prolonged in those households as opposed to a household where there's no exposure to tobacco.
And maybe they're coughing more.
Yes, exactly. They're coughing, and they're coughing longer, whereas other patients would have stopped coughing on TB treatment.
Right. Thank you very much.
Thank you.
See no other hands. So our next speaker is Jason Bacha from Tanzania, actually from Baylor, and he's going to talk on late versus early ART initiation in patients with or children with tuberculosis. So I think very important.
Good afternoon, everyone. And again, I'm Jason Bacha, working with the Baylor program in Tanzania. I'm in Mbeya. I put a map of where Mbeya is in case you don't know. And if you're ever in Tanzania, we would love for you to swing by the Baylor Center down in the south of Tanzania. And today I'm going to give a talk looking at a study where we tried to gather information on the optimal timing of ART in children who are diagnosed with TB but are ART naive. A little bit of background to this is that in adults, this has already been extensively studied. There are great review articles out there. There are meta-analysis and systemic reviews in adults looking at timing. There's a really nice current opinion piece, and already they're looking at optimal timing in MDR-TB in adults, thus leading to the recommendation of starting early within the 8 weeks. In the newest 2016 guidelines, WHO now put high quality of evidence for starting ART early within the first 8 weeks in adults. However, in children, such optimal timing has not been as extensively studied. In fact, in WHO's guidelines, there is a recommendation, but it's with low quality of evidence, really just based on one observational study out of South Africa. And they mentioned that it should be started as soon as possible and within 8 weeks for all children. Working with Baylor in our programs, this I can say is a very, very frequent question we get from other healthcare clinicians who are seeing children with HIV and TB of when should we start, how long to wait, or how soon to start. So what we wanted to do is retrospectively look at some of our patients seen at our Baylor Center of Excellence clinic in Mbeya who met our criteria, and then to look at how their outcomes and characteristics differ depending on the timing of their ART. We did a retrospective chart review for roughly slightly over a 2-year period between 2013 and 15, looking at children under 15 who had HIV, diagnosed to TB, no prior exposure to ART, and were initiated on anti-TB followed by ART. For the purpose of this talk, we defined early ART as in the first 2 weeks, the first 14 days following anti-TB initiation, and we defined late ART as after 2 weeks. And just to show you, all of our patients did start within the 8 weeks with the range between 7 days and 55 days. So we didn't have anyone outside of that 2-month period. And we gathered characteristics as well as data on outcomes, also looking at incidence of TB iris or any adverse drug events. Our favorable TB treatment outcome was the combination of cured or treatment completed. And because viral load had not yet been rolled out in Tanzania, we don't have any viral load data. Therefore, we utilized CD4 and defined favorable is mild or not significant immunosuppression based on the 2000 WHO definitions. And that is our statistical analyses tests done. So what we found is we had a cohort of 47 patients, a small cohort, and roughly almost half and half happened to go into early versus late based on standard clinical practice. To give a snapshot, these patients, when looking at all new ART initiations, were about 7% of our new HIV ART initiations. And when looking at all new TB initiations, this represented about 18% of our TB initiations. When looking at just TB HIV, which is about half of the patients we see for TB, it represented just over a third of TB HIV patients. Regarding the ART regimens, nearly 3/4 were started on an efavirenz-based regimen, and because the time period was the overlapping shift from nevirapine to Kaletra-based for under 3, there was a 21% on nevirapine and just 2 patients who were on Kaletra-based. When looking at baseline characteristics between the 2 groups, we can see that statistically significant was that the later ART group was older, but all the other characteristics were not statistically significant. What I also found quite interesting looking at the immunosuppression and nutrition and inpatient status were, not surprisingly, that these are sick children. Over half had severe advanced immunosuppression, over 70% with severe or moderate acute malnutrition, and nearly half were admitted at time of anti-TB initiation. Regarding diagnostic certainty, the total was about 17% had bacteriologically confirmed, with the others being a mix of probable and possible TB. It's not up here, but all but 4 patients had pulmonary TB, and it was 2 extrapulmonary TBs in each of the groups, and we had no cases of TB meningitis, which is an important consideration with early and late ART and iris. So looking at the outcome differences, and this is divided by the early and late, and then favorable, unfavorable for our main 3 outcomes regarding TB, nutrition, and immunosuppression. The overall picture is that there were no differences, no statistically significant differences regarding TB, nutritional, and immunosuppressive outcomes between the 2 ART initiation timing groups. Good news is that about 77% of patients had favorable outcomes cumulatively in all of the patients, and there were good trends in nutritional and immunological recovery in our groups with treatment. We did not have any reported or seen cases of TB iris in any of our 47 patients, as well as no reported grade 3 or 4 severe drug toxicity were documented or recorded in any of our patients. Of course, with this study comes all the limitations of a single-site retrospective study with a small sample size. We also were unable to really examine the causes of death, and we did not gather any information on the impact and experience of the caregivers and patients themselves, and if there was preferences or challenges or barriers regarding the 2 types of earlier versus later ART initiation. So what does this mean, and what conclusions did we draw? We found that the initiation of ART, even as early as in 2 weeks or the 7 days, in ART-naive children did lead to favorable outcomes, and we saw no differences between our early versus late, as well as no TB iris or serious adverse drug reactions were seen. And basically, the message that we like to take from this is that delaying ART initiation in these children is not necessary. They're already severely ill with their TB, with their HIV. There's already numerous barriers and delays to care in these high-burden settings with severe human resource for health crises. So it might give us some encouragement to push for an earlier initiation and not waiting and not delaying in such children. Again, fitting the new differentiated models of care, model that is encouraged by WHO, and moving away that it's not going to be a one-size-fits-all. It might be a one-size-fits-few, and often it might be one-size-fits-one patient. So again, I would like to thank, of course, our patients and their families for their courage, our hardworking staff for their dedication, and being inspired being here in Liverpool and seeing, I know with its rich musical history and the many quotes sprinkled in the program and presentations, I just wanted to add a great musical quote from one of the musical greats of Liverpool, arguably the greatest musical group, and that, of course, is Flock of Seagulls, who in their 1982 hit Wishing said, "I wouldn't spend my life just wishing. It must be something more," which I think fits very, very nicely into the call to action of the whole union meeting this year. Asanteni sana, and thank you very much for listening.
Good. We have time for a question. No questions? Yeah, 2? Okay. James?
I agree with you, and I think that we probably should have started. But your data also could say completely opposite.
It could.
It's safe to wait.
Absolutely.
So would you change on the basis of this study? I think this is great because we've had no data in this area. When someone comes to you and say, when should we start antiretrovirals and TB, what is your answer now?
Yes, the answer...
Your data do support actually, it's safe to start early, but it's also safe to wait for it as well.
Exactly, and we chose the former based on the barriers to care that we see time and time and time again. So what we say currently is to start as soon as possible, and sort of a non-evidence-based recommendation is often, what would you do if this was your child? Base it case to case. Would you want to delay knowing their HIV disease might be affecting them more and more? So again, it's not that one size fits all. We don't have a perfect answer, but it at least helps alleviate fears of toxicity, iris, or other risks of starting too soon. Right, right. Yes.
We have one more.
Thank you so much for your presentation. I also can see that the benefit of adding to the evidence base for starting early. I wondered in terms of future directions for expanding this evidence base and thinking about differentiated models of care, is there any particular group that you think should be studied more closely, in which there might be a benefit of delayed art and sheet?
I think the big one is TB meningitis, obviously. Based on our data, there was not a group that came up. And looking at some of the larger Baylor data, again, the more delays in any type of treatment initiation, we see more mortality, loss to follow-up risk. So the answer shortly is no. I don't see any specific groups other than the TB meningitis to delay, just due to, again, the barriers to care that are existing in many settings.
Yeah. The next speaker is Tony Soriano Arandes from Barcelona, speaking on the risk factors for complications and poor treatment outcomes in children with tuberculosis in Spain.
Thank you very much. I'm representing a Spanish network on pediatric TB. And on behalf of this network, I'm showing you the results of this study for complications and poor treatment outcomes in children with TB in Spain. First of all of us know that children lower than 2 years old are presenting higher incidence of extrapulmonary and disseminated manifestations of TB disease, and also contributing to overall TB mortality and morbidity with great consequences and sequelas. The impact of TB-associated complications and sequelae in children in a low prevalence country like Spain is unknown yet. Then, just to let you know, in Spain, Spain is the Western European country with more childhood TB cases, with an incidence of 4.2 per 100,000 inhabitants per year. There are in Spain 300 children less than 15 years with TB, and in 2013. We launched the Spanish network for the study of pediatric TB, mainly to determine the characteristics of childhood TB in Spain, and also to promote research in this pathology. The hypothesis we launched was that in our country, pediatric TB presents with high rate of complications and permanent sequelae. And we try to identify high-risk groups to develop prevention strategies and therapeutic interventions. The aims of this study were to determine the incidence of complications and sequelae among these cases, and also to try to identify risk factors associated with TB complications and sequelae. The methods, this is a prospective multicentric study. We used an online database, a platform used RedCap database. The inclusion criteria was all the children less than 18 years diagnosed with TB disease between January 2014 and December 2015, a total of 2 years. TB complications were defined as a clinical dysfunction secondary to the comprehension or infiltration of adjacent structures. Also, not only at diagnosis, but also after the beginning of treatment, including paradoxical reactions. The sequela was defined as a chronic dysfunction secondary to the compression or infiltration of adjacent structures. We did a statistical analysis and descriptive and logistical regression model. Regarding demographics, we include 340 children from 48 institutions, and no differences between gender. The median age was 5.3 years, and 45% of them were younger than 5 years. As you can see here, there is a very predominant regions in Spain with pediatric TB, mostly in Catalonia and Madrid regions, achieving more than nearly 70% of the total cases of pediatric TB. Also, we studied the underlying conditions for these children. 87.5% of them, we didn't find any underlying disease. HIV was really scarce, with only 2 cases of them, and other underlying diseases like chronic granulomatous disease, severe malnutrition, or sickle cell disease were observed. Regarding the site of TB, 18% of them were extrapulmonary, 4.5% TB meningitis. As you can see here, the numbers, we found 15 cases of TB meningitis, also 7 of osteoarticular TB, abdominal TB were 9, and also other sites like pediatric, pericardic, or laryngeal were observed. The diagnosis, the confirmation was achieved in 1/3 of all of them, mainly by culture, and drug resistance was really similar to the reported in National Health Services. 1.3 of them were MDR TB. Regarding complications and the aim of the study, 16% of them, 41 cases, had complications, and more than 5% of them had sequela. And regarding the sites of these complications, 14 had complications at pulmonary sites, 5 in meningeal and CNS site, 3 involving bones and spine TB, and 1 affecting lymph nodes network. And regarding the sequela, 20 cases had paradoxical TB, and regarding the sequela, the numbers are really small, but in total we had more than 5% of sequelas. Two children died in this period of 2 years' time. For the multivariable analysis, the predictors, the risk factors for complications and sequela were the age, less than 1 year. It means that the child has a 5-fold increased risk for complications. Also, the foreign, being a child with a foreign family is another risk factor for complications, and also the confirmation of the case microbiologically is another risk factor. And finally, regarding the clinical form, the TB meningitis is the most important clinical form for complications. And for sequelas, we could find the same results regarding the foreign parents and the confirmation of TB, and also for TB meningitis, osteoarticular TB, and miliary TB, the complications, either sequela, were really nearly, for TB meningitis, 15-fold increase for complications, and for miliary TB, 18-fold increase. As a conclusion, in our core, more than 15% of children presented complications, and more than 5% developed long-term sequelae. As a limitation, this is only a 2-year study. We are not able to show you the long-term sequelae along a great period of time. And also, another limitation is about the sites, the Spanish sites, because as you saw before, Catalonia and Madrid are the most prevalent regions also to report cases to the network, but also the other sites in Spain maybe infra-reported or not achieved with this network. Childhood TB complications were associated with early childhood, foreign background, and extrapulmonary TB, especially miliary, meningeal, and osteoarticular TB. And this Spanish pediatric TB database has allowed us to assess the clinical outcome of childhood TB in our country, and also reveal that TB remains a public health priority even in low incidence regions. And finally, just acknowledge all of these researchers, pediatricians, most of them, that are being involved in this network. Thank you very much.
Tony, just because you have to leave, I'm going to allow a question because he's one of the people that has to catch the train. Question? Yes, thank you.
Why do you think you've had more complications and sequelae among the patients with foreign-born parents versus?
Maybe one. This is a good question. Maybe it's a challenge for them to achieve the health system or regarding the assistance to the pediatricians, and also some of them are illegally in Spain, and that's a social real impact for us. Yeah. Mm-hmm.
Okay, thank you very much.
Thank you.
And our last speaker, but not least, is thank you for being patient. Tori Kauger from the CDC, an epidemiologist, who's going to talk on the contribution of global tuberculosis in the burden of pediatric TB in the US.
So I just want to first thank you all for sticking with me till the very bitter end of this. You are all heroes and dedicated individuals, so thank you in advance. So I have the opportunity today to present, I think, a really well-described, or a really well-documented but under-described group, which is TB among children in the United States nationally. So just a bit of context, in 2015, there were 9,563 cases of TB reported at an incidence rate of about 3 per 100,000 persons, so low incidence setting. About a little less than 5% of these cases are among children aged less than 15. And among adults, nearly 2/3 of them were born outside of the US. And from here on, I'll refer to that group as foreign-born persons. So importantly, in 2009, there were some revisions to the way that the surveillance system collected data at a national level, and there were several important childhood variables added to this. And this was an expansion of just beyond just the nativity of the child being foreign-born or US-born, and moved into the nativity of the parents and the guardians, and also any time spent outside the US in other countries. So really the goal of this analysis was to kind of characterize some of these newer documented global links to TB among children in the United States. So in terms of our data sources, we use the National TB Surveillance System, which is all cases reported from the 50 states and DC in the US, and then our denominators come from the US Census Bureau. So just a little bit of context, during our study period, 5,304 children were diagnosed with TB, and this was approximately 5.4% of all TB cases during the study period. And as you can see, during our time period, fewer cases were diagnosed as time progressed, but it was an average of about 600 cases per year. And so among children, the incidence rate is about 1 per 100,000 persons, so pretty low incidence among this group. Of all children, about a quarter were foreign-born, which is much less than we see in adults, which is about 2/3. However, the rate is about 10 times higher in foreign-born children compared to US-born children, so 7.5 per 100,000 compared to less than 1 per 100,000. So next, we kind of aim to look at this US-born group and kind of tease into what their global links to TB might be. So we first looked at the nativity of their parent and guardian, so seeing how many of the US-born kids had at least one foreign-born parent. And the answer is quite a few. So of these US-born children, over 40% had 2 foreign-born parents. An additional 20% had one foreign-born parent. So in total, more than 60% of US-born children had at least one foreign-born parent or guardian, excuse me. So when you kind of break this down and add in the population denominators and look at rates, you can see all the way to the left here are the foreign-born children. So among the foreign-born children, and this is a little bit different than the previous rate that I presented because this is restricted to the newer variables that we collected. So starting in 2010 when the incidence was a little bit lower. But the rate among foreign-born children was 6.3 per 100,000. And then when you look at children with 2 foreign-born parents, it's about half that. And so we see a little bit of a gradient for kids who are foreign-born themselves, kids with 2 foreign-born parents, which is about half the rate among foreign-born children, and then for children with 1 foreign-born parent, it's about half the rate of TB among children with 2 foreign-born parents, and it's substantially higher than children who are US-born and have no known foreign-born parent. The final variable that was kind of added in 2009 that was PEDS and global specific was whether or not the child spent more than 2 months living outside of the United States. So overall, 43% of children less than 15 spent more than 2 months outside of the US. And so among foreign-born children, this is 73.3%. And you might be asking, why isn't this 100? So for a small proportion, a little bit less than 10%, this was not reported. And for the remaining percent, they moved before they were 2 months old to the US. But among US-born children, notably, almost 12% of US-born children did report spending more than 2 months outside of the United States. So the next thing we wanted to do was kind of hierarchically stack these risk factors to see the relative contribution of these risk factors. So along the x-axis here, we have age stratification, and I'm going to focus on the bar all the way to your right, the bar that says all, just so you can kind of see a picture of the total pediatric population. So in total, about 23% of children were foreign-born themselves. And then among US-born children, an additional 9.2% had lived outside the US for more than 2 months. And then among children with neither of those 2 factors, so they were US-born and had no reported history of living outside the US, an additional 40% had foreign-born parents. So this was kind of the largest chunk that we could link for global TB. And if you look at the total, with all those risk factors, you can see that the total number of kids with one of these 3 risk factors is over 70%, which is actually comparable to the proportion of adults who are foreign-born in the United States. But also notably, there are almost 30% of these children with none of these 3 risk factors. So when we kind of break this apart by which countries these children are linked to, you can see that Mexico actually has more of these links. And when I say links, I mean the 3 risk factors previously mentioned, either being foreign-born from that country, US-born and spending time in that country for more than 2 months, or having a foreign-born parent from that country. Mexico predominates, being that it actually accounts for as many cases as the other top 10 combined. And if I can direct your attention to the blue bar, which is the proportion of children who are, or the number of children who are foreign-born, you can see that the blue bar is approximately the same as what it is in some of the other high-burden countries, and that there are not many more foreign-born children from Mexico than there are from, say, Ethiopia or Myanmar. It's really this nativity of parent and time spent outside the US that predominates in these children who have a link to Mexico. And you can actually see that some of the countries have a different kind of distribution of these risk factors depending on the region of the world. Notably similar to Mexico are Guatemala and Honduras, also in Latin America. So kind of changing directions a little bit, we next wanted to look at foreign-born children specifically and look at how long these children were spending in the US before they were diagnosed with TB. And the answer is not very long. So 40% of children were in the US for less than 3 months before they were diagnosed with TB. And almost 2/3 of foreign-born children were diagnosed within 1 year of entry. In terms of looking at how this translates into rates, we looked at people who enter the US as children and rate by time in the US since entry. And that is along the x-axis you can see here. So this first peak, and obviously very high, is the children who have spent less than a year in the US. And you can see after 1 year, this drops off quite substantially, but still kind of lingers a little bit higher than what we see in US-born children, which is this dotted red line here. But it is relatively stable, probably representing transmission ongoing in the communities in which these children live. So we also have evidence that this varies a little bit by where the children are from themselves. So this x-axis here, sorry, this is a little bit busy, so let me kind of orient you. X-axis here is the median time in the US before diagnosis and stratified by individual country. The y-axis is rate among children from that country, and the size of the dot is proportional to the number of cases it represents. The color is world region of birth, and these are US Census Bureau definitions of world region and not WHO. Just as a note, I think Russia actually might be considered Europe in census data. But you can kind of see that, well, the most obvious one outlier is Mexico, and Mexican-born children are spending a lot more time in the US before they're diagnosed with TB compared to a lot of the countries in Africa and Asia, where the median time in the US before diagnosis is far under a year. So in terms of limitations, we've kind of highlighted some links, and they're just that, they're links. They could potentially be misclassifications, and they're not necessarily the source of infections for these kids. So for example, having a foreign-born parent from a country does not mean that that parent is the source, or that even country was the source, I suppose. But the opposite can be said too. The absence of a link does not necessarily preclude some sort of association or exposure to outside of the US. For foreign-born children, we're unable to distinguish whether infection or disease is acquired overseas, and this is kind of an artifact of our data and databases that we use in the US to look at these data. And in places there were lacking or difficult denominator data. So for instance, it would have been interesting to look at rates among children who spent time outside of the US, but that's not something that's currently captured, at least to my knowledge, in some of the data sources we were looking into. And the rates for parental country of birth, we kind of wanted to stratify this idea that having a foreign-born parent increases your risk, but that was a little bit, we'll have to do some linking, so that's a next step. So in terms of conclusions, more than 2/3 of children with TB are either foreign-born themselves, have spent more than 2 months outside the US, or have at least one foreign-born parent. And of all children with TB in the US, 1 in 4 of these children has a link to Mexico. One of these 3 characteristics. Compared to US-born children without foreign-born parents, rates are higher among foreign-born children and US-born children with foreign-born parents, with a little bit of the gradient that I described. And for foreign-born children, most of these children were diagnosed relatively early on in their stays in the United States. However, we do have some evidence that this may vary by country of origin. So I'd like to acknowledge all of the people that collected this data and helped me analyze it, including the states, jurisdictions, and localities. Thank you.
So we still have 2 or 3 minutes before the end of the session. So any questions to Tori or to any of the other speakers? Yes. Sorry.
Yeah, and it is more proportional than you would think. And we're still kind of digging a little bit more into the country-specific data. But yes, it's not entirely unexpected.
And
some way of knowing how the case was identified, referral, or they contact follow-up, or were they sick?
Yeah, that's a great question, and the answer is we do. It's collected on our form for submission from the states. The answer is it's a little bit heterogeneous in the way that the states and programs fill it out, so you have to interpret it with a little bit of caveats. But the answer, I think that the question that you're kind of implying is, are there differences in the way that these people were, or these children were identified based on some of the factors that I just mentioned? And the answer is Yes. So children who are foreign-born were less likely to come to the attention of the TB program through active case-finding strategies, contact tracing, targeted testing, yes, but foreign-born children were less likely to come to the attention through contact tracing and more likely to present, or at least being coded as presented via symptoms compared to US-born children. And that also varied with parental nativity as well.
Do you have information about the mental status of the children or their parents? I was just surprised at how much disease was early, as I thought patients or children are coming into the country are screened for TB disease or infection.
So,
Did everyone hear the question?
so
Yeah.
I'll repeat the question. So the first question was on the legal status of the children on entry. The answer is we have some information on that. Some states or localities choose not to report that data intentionally. There are several ambiguous categories on that may kind of capture this group that you're talking about. And we did see some kind of associations with that, but I think it's important to note that only certain people get these medical screenings overseas. So if you're coming in on an immigrant visa or a refugee visa or a family visa, you get this medical screening by a panel physician of overseas. If you're coming in on a tourist visa or other visa status, you may not get the same screening that somebody entering under an immigrant visa may. And another kind of weird caveat of the way that we screen overseas is that at least my understanding is that it is really meant to capture infectious cases of TB and not necessarily to diagnose kids with TB. So this group that we see, this big peak and drop-off incidence at the beginning compared to 1 year, is probably a mix of contacts of kids who have TB disease, kids coming over with latent TB infection who are quick progressors, and kids who are probably sick overseas, because the travel restrictions that are put in place for treatment overseas are microbiologically confirmed TB, which, as we know, is hard in kids and isn't happening a lot.
One last question, yeah.
One quick question, because in Canada, most of the pediatric TB is indigenous, i.e. American Indian.
Mm-hmm.
You know that?
So if you look at we did look at a little bit at the top of that bar, these kids with no known risk vectors, US-born, no foreign-born parent, and no time spent outside the US. We kind of said, who are these kids and where are they presenting? And that's actually part of a little bit further analysis. So we're doing some geospatial links. And the answer is it's kind of a mixed group. So there are quite a few Alaskan Natives and American Indian children in this mix. But there's also a little bit of evidence to suggest that these kids are also living around areas where we've known to have seen TB outbreaks, and areas that are generally higher poverty. So I think it's a little bit of a mix, is this group with no risk factors.
So then thank you very much. So it remains for me to thank all the speakers and all the participants, all the people that remain to the end. Just remember that we still have the final, what do you call that? The rapporteur session, just hereafter. So it's not the final session yet, but thank you very much for being here, and thank you, Karsit, also for co-chairing. Thank you.